I was asked to talk about hepatitis B. One potential topic would have been comparing APASL and AASLD guidelines, but given that a lot of us just came back from AASLD, I thought it would be a good opportunity at this conference to share highlights with regard to Hep B topics that were presented at the meeting in November in Boston. And so I wanted to focus on kind of a few areas. One of them being this whole idea of HCC risk reduction. As we know, antiviral therapy does reduce the risk of HCC, but there has been emerging interest in looking at the difference between the different antivirals, going over kind of the continued clinical data on the TAF studies. There were a bunch of abstracts on real-world experience with TAF, and then just kind of finishing up with additional highlights. So that will be the outline of my talk. Okay, I'm getting the hang of this. So back to HCC risk reduction, and we just finished a talk looking at liver cancer, and there's a lot of interest in, are there differences in these antivirals? And right now, there's basically three main choices, right? There's entecavir, there's TDF, and there's TAF. And so the background on HCC risk reduction is that HCC incidence was recently reported to be lower in a subset of Asian chronic hepatitis B patients treated with tenofovir over entecavir. This has been shown in a few studies, but is by no means controversial. This was reported by Choi et al. In a Korean nationwide cohort study. They looked at 24,156 treatment-naive adult patients in a retrospective study from January of 2012 to December of 2014. And they were looking at cumulative, and this was not presented at AASLD this time, but this was a background to some of the stuff that is being presented or was presented at the conference. They examined a cumulative incidence of rates of HCC and death and transplant rates. And they found in the study that the annual incidence rate of HCC was 0.64 per 100 person years in the TDF groups versus the entecavir group, which is 1.06 per 100 person years. And in their multivariate adjusted analysis, TDF was associated with a lower risk of HCC, and that number was a hazard ratio of 0.61 with a significant confidence interval. So that was interesting, right? And then at EASL earlier this year, another group reported similar findings. They also reported that tenofovir treatment was associated with a lower risk of HCC compared to entecavir in a cohort of chronic hepatitis B patients in Hong Kong. They looked at consecutive patients who had received either drug over a 10-year period, and they used fancy statistical analysis, including multiple imputation and propensity scores. And with matching, they concluded in their study, which was recently published in Gastro just in September, that tenofovir was associated with a lower risk of HCC compared to entecavir after propensity score weighting and fancy matching. So what was presented at AASLD this year? Oh, I'm doing both, so sorry. What was presented at AASLD this year? So there were a good amount of studies that looked at this question, comparing tenofovir to entecavir and looking at HCC incidence. And here are listed some of the studies that were presented and kind of what regions they concentrated on. So a study by Choi that was abstract 484 looked at a global population. I have here the N values in terms of the number of patients, the study methodology, and whether or not these studies were significant or not. And so I'm focusing on these 7 studies. These are all retrospective observational studies. This is just essentially just a list of them. These are not compared head to head. So I don't want you to think from this graph that, okay, now these 7 studies were compared against one another. But as you can see, it's not clear cut, but it is an interesting topic. Is one drug favoring reducing a risk of HCC? So it's an interesting question to ask. And the ones that are highlighted in orange tend to favor tenofovir as potentially protective against developing HCC. So this first study by Choi, which was presented, was a systematic review and a meta-analysis that was presented. So they did essentially a PubMed Medline search from inception all the way up until April of 2019. The authors are from Korea, and they looked at a total of 11 studies, and I believe a grand total of around at least 55,000 patients were included. And they showed here that tenofovir was associated with a significant reduction in the risk of HCC occurrence, with the hazard ratio here of 0.77 with a significant confidence interval that does not cross 1. So they essentially concluded that tenofovir was associated with a significant lower risk of HCC in patients with chronic Hep B compared to entecavir therapy. And they also kind of separated out using forest plots, using propensity score matching on the left side, and then on the right side they looked at a subset of patients with cirrhosis. And even kind of looking at these subsets, they still found a kind of significantly lower risk of HCC, again with a hazard ratio on the left of 0.73 and on the right a hazard ratio of 0.80. Dr. Kim looked at a study, this one, now we're moving to the United States here. And so they did a study looking at administrative claims. Oh, sorry, I'm not switching the slides. Okay, so this is Dr. Kim's study, looking at administrative claims analysis in the United States, going back from 2006 to 2018. Their study design was looking at medical claims data. The patients in this study had to have at least a year of enrollment in the kind of insurance plan. And then the observation started with the patient's first treatment with either drug, and the observation period ended at the time of either a claim of HCC, liver transplant, their insurance came to an end, or at the end of the study date, which was September 30th, 2018. And as you can see here, these are some of the demographics of the patients that were included, without a huge number of differences between the tenofovir group and the entecavir group. And what they found, again, with propensity score weighted analysis, was that there was an association of a decrease in the long-term risk of HCC. When you look at the rates of HCC, their study reported 0.31 per 100 person years, and for entecavir is 0.60 per 100 person years. And the overall risk and the adjusted hazard ratio was significant at a hazard ratio of 0.61. And so these findings are consistent with some of the other studies that I have discussed. And so another study that was presented, this looked at a cohort of patients, looked at a cohort of patients in the REAL-B consortium. I'm gonna compare the two. Here we go. In the REAL-B consortium. The REAL-B consortium is a consortium looking at hepatitis B patients that's across 19 centers from 6 countries and regions. And so this was another retrospective study. And so this was interesting in part because you're looking at both an Asian as well as a United States population. And they, in their unadjusted analysis, there seemed to be an association with the lower risk of HCC. So as you can see up here in the unadjusted analysis in this top right-hand corner, there seemed to be an association with a significant p-value, but when you do the multivariate analysis, it did not become significant. So this association no longer existed after multivariable adjustment as well as propensity score matching. And in terms of the difference in populations, again, there wasn't too big of a difference between the entecavir cohort and the tenofovir cohort. And as you can see from the graph here, there wasn't a huge difference. So this study reported that while there might have been a trend, there was not a significant difference in the end. Okay. Here is another study. This one was out of Taiwan, a retrospective study, again, comparing the incidences of HCC development. And here they found that TDF treatment lowered the risk of HCC development compared to entecavir treatment with similar results after propensity matching. So they reported that there was a difference. This is a population looking at veterans in Taipei, and they had a numerically lower incidence of HCC observed, but the difference did not reach statistical significance. So while there might have been, again, a trend, it was not thought to be statistically significant. And they looked at not only all patients in their cohort, but they also specifically looked at patients with cirrhosis. And none of those values were kind of in the significant usual cutoff of a p-value of less than 0.05. Here we move on to France. The authors here looked again at the same question, and they did not show a difference in the French cohort. They looked at 1960 patients over a mean follow-up period of 45 months, and they looked at not only HCC, but they also thought they'd look at liver-related complications. So not only looking at decompensation, all-cause mortality, as well as liver-related death. And there were no differences here in this study. So you can see that they graphed, if you're in tenofovir versus entecavir and all the different potential outcomes. So there was no difference reported here. And then this is a study, I believe this was done out of Greece, and this was looking at Caucasian patients and their risk of HCC. And there was not a difference in the cumulative HCC incidence, as you see from the gray line for tenofovir and the blue line for entecavir. The log rank was not significant and the curves are almost overlapping. So, it's further studies need to be done. Most of these, I believe, were retrospective. So there's no huge take home other than, there's very much emerging interest in whether or not one drug is more protective over the other. And this is just kind of a master list, if you will, of all the different studies that I just discussed. And again, their statistical methods that were used and what their study size was, what the follow-up period was, what types of patients did they look at, treatment history of the patients, what the HCC incidence was, as well as what the overall results were. But again, these studies haven't been compared against each other, but this is essentially a summary of what was presented on this topic at AASLD. Another study that I thought was interesting, also out of Korea, looked at ALT normalization after entecavir and tenofovir and correlation with reduction in HCC development. So what they did here was looking at, after 1 year of therapy, whether or not ALT normalization had anything to do with HCC. And these authors concluded that it is relevant. ALT normalization after 1 year is correlated with the reduction of development for HCC. And so the green line is their ALT is not normalized. And they used a cutoff, I believe, of an ALT of 30 for women and 34 for men. And in the blue line, you see with ALT normalization, your kind of risk of getting liver cancer is a little bit lower, again, with a significant p-value. Okay, so I'm going to switch gears here. So those were kind of studies looking at different drugs and their impact of HCC. And what I'll switch to now is kind of some of this other additional studies that have been done studying TAF. In previous meetings, we've learned, from the previous meetings that TAF does show bone density and renal protective effects. And so this is a continuation of looking at TAF and chronic hepatitis B patients who are switched from tenofovir who have other risk factors. And so at least for some of the patients that I see, either TAF is on a formulary or the patient has to have a certain risk factor such that the insurance will approve that they'll get switched. And usually the classic risk factors include an older age, usually it's age greater than 60. They have to have evidence of osteoporosis of the hip and spine, stage 2 CKD, albuminuria, hypophosphatemia, and other comorbidities associated with CKD, such as hypertension, diabetes, and obesity. So in this study that was presented, patients had been already virologically suppressed on TDF for greater than or equal to a year, and they either continued on, they were randomized in a double-blind active controlled study. So they're either randomized to continue with TDF or to switch to TAF. And at week 48, their endpoint was to look at viral suppression, HBV DNA less than 20 IUs per ml at week 48. And so essentially, they concluded that in chronic hepatitis B patients with risk factors to TDF, the ones that I had mentioned earlier, like renal dysfunction and osteoporosis, viral suppression was maintained with numerically higher rates of normal ALT. And so basically, the patients that had switched continued having viral suppression, and they also maintained or had slightly better rates of normal ALT at week 48 when they looked at their study endpoints. Here, they looked at the changes in eGFR, and so switching from TDF to TAF demonstrated improvements in renal function in patients with greater than or equal to 1 risk factor. And so as you can see on the right side, the patients who would switch over to TAF, they have an increase here in their glomerular filtration rate that was significant. And that's consistent with some of the other data we had heard about earlier. They also, again, looked at bone density. They looked at changes in the hip bone mineral density. They looked at changes in the spine bone mineral density. And all the kind of upsloping graphs show an increase in bone mineral density in both the hips and the spine, and that were significant. Okay, and so another study that was presented at AASLD was looking at patients with Hep B who had renal as well as hepatic impairment. So I'm first going to talk about cohort 1 and cohort 2. Basically, patients who had already been virally suppressed, they were then switched to TAF daily for 96 weeks. And they looked at patients who had moderate to severe renal impairment, and there were 78 people in that cohort. And they also looked at a cohort of patients who had end-stage renal disease. And again, they're looking at all the similar endpoints, whether or not there was an improvement in GFR, whether or not there's improvement in hip and spine bone mineral density, as well as ongoing suppression of HBV DNA, as well as whether or not patients had adverse effects or not. And so a lot of these results are not very surprising, but switching to TAF and CHB patients with renal impairment, they were able to maintain viral suppression. And that's the graph on the left side here. And they were also able to have a high rate of normal ALT. So these are all positive findings. And renally impaired CHB, including those with ESRD on hemodialysis, switching from TDF to TAF resulted in stable or improved renal and bone safety. So again, here you see in the total that all the graphs above the x-axis show that the changes in bone mineral density are all quite positive. They also looked at patients who had hepatic impairment. One caveat is I believe that they could have hepatic impairment at the point of enrollment. So the child Pew score, I think they had to be greater than or equal to 7. I don't think they could be more than 12. And it's possible that they could have had a elevated child Pew score, and later on in the study it could have been lower. But they did look at patients with hepatic impairment, and switching to TAF and CHB patients with hepatic impairment, again, they were able to maintain viral suppression and an improved rate of normal ALT. And again, renal and bone safety were preserved. Okay. The third part of my talk is to talk about what other real-world studies. So we talked about, 2 drugs and whether or not there was a reduced risk of cancer. Then we talked about clinical trials that had to do with TAF. And now we're going to talk about a few studies that looked at real-world effectiveness of TAF in chronic hepatitis B patients. This was out of the target HBV cohort. They looked at 499 patients enrolled at 26 sites. And, this was just kind of an observational study. The authors kind of detailed, what are reasons why patients switched over, and so, for vast majority, you didn't have a reason recorded, but you also had the safety profile may have influenced a clinician or a patient's decision to ask to switch over. Some of it was physician choice. Some of it was risk of bone and renal disease. Some of it was patient request, copay costs, insurance changes. But the efficacy outcomes were such that switching to TAF from another regimen was pretty well tolerated and associated with further improvement in serum ALT, ALT normalization, as well as maintenance of viral suppression. This study looked at longer-term experience in TAF and Hep B infected patients, and they looked at treatment after greater than or equal to 48 weeks of treatment. And here they saw, again, similar results. Hep B DNA suppression is maintained, ALT normalization is maintained. And so, yes, they also showed statistically significant improvements and DNA suppression ALT, but not so much necessarily in the GFR. So I thought that was interesting. That p-value for an increase in the creatinine clearance in this kind of real world 48-week study didn't show a significance there. And this study was, again, looking at more kind of real world cohort data. And this was data out of both US and Taiwan. And they were looking at, again, viral suppression and mean EGFR levels. Mean EGFRs were similar for the total cohort from TAF switched to 12 months, but there was a subgroup of patients, and I think it's the green line. Yes, that was a significant curve. They had a significant improvement with a mean EGFR increase. So the patients who actually started off, I believe, with the red graph. So the red graph was at their EGFR at the time of switch. So this was a retrospective study looking at patients who were switched to TAF. And the red line, if their EGFR was greater than 90 at switch, they didn't have any like significant improvement, but the patients who started off with their GFR in the green line a little bit lower, they had some improvement. Here's another study that looked at switching from TDF to TAF in patients with multi-drug-resistant Hep B, and these were patients who had demonstrated resistance to either entecavir and or adefovir under tenofovir monotherapy for at least 96 weeks, and they were randomized either to TAF or to continue TDF for 48 weeks. And switching to TAF maintained viral suppression and guess what? Improved normal rates of ALT at week 48. Again, here are the changes positively associated with improved renal function and bone mineral density. Okay, and then the last part of my talk is additional highlights that I saw at AASLD. And this is looking at Hep B prophylaxis post-liver transplant. I think more and more of us in our post-transplant patients, either because they have renal issues, maybe switching over to TAF. And here are some data from a study. This one, I believe, was out of Greece. It was a single center real world study looking at renal function and serum phosphorus. And patients switched in this study if their insurance would approve them. And so in Greece, the indication for patients to switch over to TAF, they had to have either a low GFR or they had to have a low serum phosphorus. And in this study, there wasn't anything amazing, but it says it tended to stabilize the rate of kidney function deterioration, and they didn't really present it in their poster, but they said in their summary that it helped correct the hypophosphatemia that some of the patients had. I believe this was a study out of Stanford looking at care gaps in the treatment cascade for hepatitis B. I think a lot of us are familiar with kind of cascade graphs back when Hep C baby boomer screening was when that recommendation came out, and there was a lot of interest looking at kind of cascade of care for hepatitis C treatment. But it's interesting that not a lot of people have looked at it with regard to hepatitis B. And I think this, I'm not surprised by this data, but I think it's really important to present in that, you have a lot of patients who they looked at, I believe, Optum database from 2003 to 2017. So you have a large burden of disease. So they had about 7,000 patients who were diagnosed with hepatitis B. But as you can see, then they looked at patients who had an evaluation, patients who had an evaluation within a year, and they looked at treatment eligible patients based on, I believe, AASLD treatment guidelines and how many of those patients were treated. So as you can see at the last end of the graph, there's very few patients that are treated. So there's definitely a huge care gap in terms of identifying patients with Hep B and making sure they're getting an evaluation. And in this study, they defined an evaluation or a laboratory evaluation as having e-antigen labs, Hep B DNA, and ALT during the entire study observation period. So basically very few people, only a little bit over a quarter of the patients had a complete evaluation within 1 year of diagnosis. and only less than 20% of the patients eligible for treatment received antiviral therapy. So significant care gaps still exist in Hep B, although we do have quite effective therapies for this. This was a study done by folks at the CDC. It was just kind of an epidemiological study looking at age-adjusted death rates associated with hepatitis B in the United States. As you can see from the dark navy blue, that's where you have the highest death rates from hepatitis B. So not surprising in the West Coast where there is a higher prevalence of Hep B based on the population there. But what I actually found surprising was kind of this cluster of states down in the southern U.S. and also the Appalachian region. So, one theory for that was that maybe some of those patients were both co-infected with both Hep B and Hep C co-infection. What was interesting was that 64% of the Hep B related deaths were among US born persons. So I thought that was another interesting observation because a lot of us, especially in the Bay Area, as we're treating Hep B, we're thinking of, treating at-risk patients from an endemic population. But if you look at the epidemiological data from the US, 64% deaths from US born patients. And so you guys have a number, 17,000 Hep B related deaths were reported. And the mean age of death is 60 years old. This is a slide that I stole from the best of AASLD from viral hepatitis. This was interesting just because of all the novel therapies that are coming out. I didn't focus on a lot of the basic science in terms of kind of therapies for potential cure of Hep B, but I thought this was cool in that there is a nasal vaccine that could, pose as novel immune therapy for achieving functional cure. So what they did, and this was a study out of Japan, they looked at Hep B surface antigen reduction by a nasal administrative therapeutic vaccine that contains both surface antigen and core antigen. And they found that this vaccine reduced Hep B surface antigen in 70.1% with patients who were treated with nukes and 76.5% that were not treated. And 4 patients out of that study achieved functional cure. So more to come on that, but exciting data that was being reported out. I think I have a couple other abstracts to present, and then I'll wrap up. This was a study by Dr. Khalili at UCSF. She's part of the Hep B research network, and they looked at liver biopsies from 420 adults in their cohort. And they were looking at what is the relationship between fatty liver and in these hepatitis B patients, as fatty liver has emerged as a cofactor influencing disease progression. And they were looking at what's the relationship in these Hep B patients between fatty liver and advanced fibrosis. They found a positive association that having steatohepatitis compared to steatosis or no steatosis, not surprisingly, puts you at advanced risk for advanced fibrosis, including other things such as increased age, will put you at increased risk, higher viral load, higher ALT. And so, the take-home point for this would be it's, in your Hep B patients, it's very important. And, I think a lot of us see both Hep B and fatty liver in a lot of our patients, whether or not they have lean NAFLD or not lean NAFLD, to screen for these metabolic abnormalities, in addition to achieving viral suppression in these patients. I thought this was another interesting study. This was looking at association between anti-platelet therapy and HCC risk. There have been prior studies that have reported an association between aspirin use and a reduced risk of HCC. This particular study, I believe, came out of Hong Kong. They looked at patients between 2008 and 2018 and looked at not only anti-platelet use and aspirin monotherapy, but they also looked at dual anti-platelet therapy, which is abbreviated as DAPT. And so they saw here, based on their multivariable analysis, that there appeared to be a protective effect using dual antiplatelet therapy. Obviously, that's a retrospective study, and we need to understand that a little bit more, but that was an interesting abstract that came out of the meeting. So in summary, I hope I was able to kind of give you a flavor of some of the abstracts and presentations that were given in Boston, starting from looking at antiviral therapies and the risk for HCC, and kind of the ongoing data looking at TAF and its safety profile, and then to stress kind of the basics, which is care gaps continue to exist for these patients along the Hep B treatment cascade, and also reporting that there are a lot of new emerging therapies out. A lot of it's very basic science heavy, so maybe for the basic science folks, they can give a talk on that next year, and that there is this nasal administrative therapeutic vaccine that is showing some promise. In your patients with NAFLD and Hep B, make sure that they're being screened for their metabolic abnormalities, and that we're also treating their metabolic syndrome. And that's it.